Welcome to the new members. These are the learning objects. So definition of the diabetes, some of the important milestones, what is the magnitude of the problem of the diabetes, what are the basics of the normal metabolism and its hormonal control, and what about the pathology and pathophysiology of the type 2 diabetes and its metabolic consequences. So this is an index case. A 52-year-old male comes to you with the blood glucose values of 198 and 362, fasting and postprandial respectively. Is not no family history of diabetes or no personal history of the diabetes so far, and discovered these values during a routine health checkup. So these are very common in our routine practice, that lot of the people living without knowing that they are having the diabetes, when you advise them any blood sugar values, so definitely these blood sugar values are very high in some of the individuals, maybe because of your insurance checkups or maybe your preoperative checkups, etc. So my question is, what proportion of the patients with the diabetes are unaware that they have the condition? So in India, nearly 50% of the people, they are living without knowing that they are having the diabetes. So it's a very high amount because of the lack of the periodical checkups in our Indian population. Whereas the Western countries, so they get the blood sugar tests or other investigations at least once in a year, so that they can pick up the diabetes much early when compared to the Indian population. So what symptoms can alert one to the presence of the diabetes? How common are these symptoms? You know the lot of the symptoms of the diabetes, but unfortunately 90% of the individuals, they don't have any symptoms. So if you ask you a leading question that what is the most common symptom of the diabetes, your answer should be no symptom at all. So asymptomatic are very common in type 2 diabetes, and of course few symptoms like your polyuria, polyphagia, polydipsia, asthenia, lack of interest, headache, sleeplessness, paresthesias, breathlessness, chest pain. So these are all symptoms because of the complications of the diabetes. Suppose he develops the peripheral neuropathy, then he presents to you with the symptoms of the peripheral neuropathy. If he develops an ischemic heart disease, he presents to you with the symptoms of the cardiac problem, maybe breathlessness or the chest pain, etc. What complications of the diabetes can a patient have at the time of the first diagnosis? In India, we are not diagnosing the diabetes much early because of the several reasons. A lot of the people, they present with the complications at the time of the presentation itself. So nearly 50% of our diabetics, 40 to 50% of our diabetics, they present with the complications at the time of the first diagnosis. So that means diabetes not being diagnosed by the general practitioner or a physician or an endocrinologist in India. So what the general practitioner or a physician or a endocrinologist diagnosing the diabetes only 10%. So the 90% of the diabetes being diagnosed by the other specialties. Sometimes I get the referrals from the ophthalmology friends saying that loss of the vision. He approached an ophthalmologist and he examined the retina. So there is a proliferative diabetic retinopathy or vitreous hemorrhage or retinal detachment leading to the sudden loss of the vision. Then he asked the leading question, what is the duration of the diabetes in you? The person says, I have no history of any diabetes. I am not a diabetic. And you ask the sister to check the blood sugars, the blood sugar is 400. So that means that he is living with the diabetes till he gets the proliferative retinopathy and then present to an ophthalmologist. The same examples you can apply to any specialty except the forensic medicine. So I get a referrals from the OBG friends. So presenting in the first antenatal visit. Last week only I have seen one patient. First antenatal visit, the OBG ordered the blood sugars, fasting 200, postprandial 300, HbA1c 14.2%, age 32 years. Imagine, when she approached me, I take an history that both the parents are the diabetics, he is obese since the childhood, lot of acanthosis nigricans, abdominal adiposity, and she is obese, around 85 or 86 kgs. The BMI is about 30.5. Lot of history of the miscarriages, abortions, etc. So these are all because of the diabetes. So it's not the gestational diabetes. Gestational diabetes means in the second half of the pregnancy. So the diabetes first occurring between 24 to 28 weeks of the pregnancy is the true gestational diabetes. That means second half of the pregnancy. If you see a diabetics in the first half of the pregnancy or in the first antenatal visit, this is considered as the pre-gestational diabetes. PGDM, not the true GDM, but you add P, that is PGDM. So how to treat? Very difficult, because we have to initiate the insulin on the day 1. Organogenesis. So what are all the intrauterine pancreas, intrauterine heart, or the lungs, or the kidneys, etc., etc. Organogenesis occurs between 10 to 14 weeks of the gestation. Suppose if the blood sugars are very, very high during those periods, obviously the child will have, the newborn will have a congenital heart disease, maybe ASD or VSD or Fallows, or maybe a defect to lung maturation, and also spina bifida, lot of the neurological abnormalities. So all these you see it. So the pre-gestational diabetes, that means diabetes complicating pregnancy, is a very, very big problem in our Indian population. I admitted her. I started her on intensive insulin therapy. So 3 shots of the regular insulin before the breakfast, before the lunch, before the dinner, and 1 shot of the long-term long-acting insulin like your Lantus or Glargine or the Deglutec or Tresiba at the night time, and then get the blood sugars at least 4 times a day, fasting blood sugar, pre-lunch blood sugar, pre-dinner blood sugar at the 10 p.m. and adjust the dosages accordingly, so that you should reach a stage of euglycemia as early as possible, not at the cost of hypoglycemia. Okay, if you introduce the hypoglycemia by giving more and more insulin, so obviously the patient will have a lot of hypoglycemic symptoms, and severe hypoglycemia is very close to the death. He is not in a position to recognize you, he is totally unconscious, froth in the mouth, convulsions. If left untreated, going to die in a few minutes or the few hours because of no blood sugar to the brain. If the blood sugar comes to nearly 20 or 25, 30, then the brain becomes no function at all. So these are very common in our individuals once you start on insulin therapy. So get the blood sugar done, put your targets, start insulin, and reach those targets without getting hypoglycemia. That is very, very important. So second case, a 55-year-old male of 42 years duration. You are pleased to find that he has absolutely no evidence of any chronic diabetes complications. Possible. See the age, 85 years. Okay. So what is the duration of the diabetes in him? 42 years duration. So he got the diabetes at the age of 40 plus. But now, no complications at all. You examine the nervous system, absolutely normal. You get the urine protein, nil. Get the creatinine and urea, normal. Get an ECG, no LVH, no ischemic heart disease. Get the 2D echo, ejection fraction is 50 or 60 or 65%. No LVH, no diastolic dysfunction. And get the SGPT, SGOT, they are the normal. And get the elastography of the liver, no fatty liver. So these are all possible, provided you control the blood sugars from the day 1. This is called metabolic memory. So in the initial days of the diabetes, management is very, very, very crucial not to have the complications at a later time. If you control the blood sugars very effectively from the day 1 of the diagnosis of the diabetes, you are going to avoid the long-term complications in those individuals. If you don't diagnose the diabetes early, if you don't treat the diabetes very effectively in the early days, obviously, even though the blood sugar control is good afterwards, so these people are definitely going to get the complications at a later time. So this is called metabolic memory. So this fellow now is 85 years with a 42 years history of the diabetes, absolutely normal. They are still under your care only. You are all going to be the diabetologists. So don't refer your diabetology cases to me or to a cardiologist or to a nephrologist for any management. When you are going to refer? When they have the complications. When they don't have the complications, every time they come to you and their fasting blood sugar is 110, their postpone blood sugar is 110, 140, and their HbA1c is 6 or 6.5, why should you refer? In an asymptomatic individual and no complications at all. That should be your aim. So your aim is two things. Diagnose the diabetes much early. Number two, introduce the medications much early so that you should control the blood sugars very effectively. And then the most important third point is long-term management. Follow-up. That is very, very important. So you should have very good bond with your patients and maintain that bond till his last days of the breath. So that is the very important in the diabetes management. Menopausal woman, 65-year-old, evaluated for the diabetes and its complications. So obviously this is the word, evaluated for the diabetes and its complications. That should be your motto. Not only for the evaluation of the diabetes, but also you should look for the complications because we are living in the India. In India, 40 to 50% of the diabetics, they present with the complications at the time of the diagnosis itself. So that means if you are seeing the two cases of the diabetes, one fellow is a simple diabetic, another fellow is a complicated diabetes. So on the day one, you should diagnose, you have to evaluate for the diabetes, that is fasting blood sugar, PP blood sugar, HbA1c, etc. And also for its complications, you have to write urine proteins, urine microalbuminuria, urea, creatinine, fundus examination, LVH, so your ECG examination. Okay, so these are all very, very important. She has diabetes of 16 years duration at the age of 65 years. She got the diabetes at the age of 49. Okay, so she has found to be fasting at the postprandial 108 and 146. Excellent. Fasting 106, postprandial 146. Very good results. And HbA1c 6.8. So your target is 6.5. Okay, up to 7, no problem. But 6.5 is always ideal. 6 is much more ideal. Further evaluation reveals the presence of proteinuria. Proteinuria means nephropathy. So nephropathy and retinas are close friends. So all the kidney patients should be screened for the retina and all the retinopathy people should be screened for the nephropathy. So these are good friends. So she had proteinuria and then referred for the retina examination. Retina also have non-proliferative diabetic retinopathy. See, just age 65 years, 16 years diabetic life. Now the blood sugars are very good. HbA1c is also very good, but had proteinuria, nephropathy and retinopathy. So why should this patient with apparent good control of diabetes develop complications? So because of your metabolic memory. So early days, she is very reluctant in taking the medications. Very late, last few months or few years, she is on very good management. Now the blood sugars are under good control. HbA1c means last 3 months average. Fasting and PP means today's values. But what is the duration of diabetes in her? 16 years. So those 16 years of poor control of the diabetes, those 15 years or 14 years or 13 years or 10 years in initial years, poor control made her to get the complications. So the patient concedes that last one, diabetes control had been poor for the past 5 to 6 years and has only recently improved following initiation of insulin therapy. Earlier they were under someone care. Now they are under your care. You are doing very good in the diabetes management. Now you are making that girl, that woman, postmenopausal woman, euglycemic. But what about her earlier days? That's gone. So she also has uncontrolled hypertension. So these two are very close friends. Again, diabetes and hypertension. So all the diabetes should be screened for the hypertension and vice versa. And diabetes and hypertension, you have to give more importance to the hypertension. Of course, as a diabetologist, you are all giving a lot of importance to the diabetes. That doesn't mean that hypertension is not important, but hypertension is much more important than the diabetes. In a combination of the diabetes and hypertension, for the simple reason that hypertension will aggravate all the complications of the diabetes. Suppose if the patient is having the proteinuria and also hypertension, if you don't control the hypertension, these fellows in the next visit, the creatinine will be 3.5. This visit, Hypertension you don't control properly. This visit the ECG is the normal, and the next visit ECG shows LVH. Okay, so these are very important. So she had hypertension, not under good control. She had the diabetes for the 16 years. Earlier years not good control. So that is the reason she made her kidneys and retina to suffer because of the long-term complications of the diabetes. So this is a very good definition. It's a metabolic disease, diabetes. Of course, you all know that it's a carbohydrate metabolism, not only carbohydrate, pan-metabolic, carbohydrate, protein and the fat. Come vascular syndrome. So it is a big vascular disease. So what is the most common cause of death in diabetes? Myocardial infarction. So myocardial infarction is nothing but a vascular death. So all the diabetic individuals should give a vasculoprotective drugs. You have to protect the vessels of all these diabetic individuals. So how to protect the vessels? Number one is stop smoking. Okay, smoking damages the vessels, causes endothelial dysfunction. Okay, and then the obesity. Again, obesity will damage the vessels. Okay, so sleeplessness, sleep deprivation, insomnia, again damages the vessels. Okay, non-dipping of the blood pressure during your sleep. During the sleep, the blood pressure has come down. Okay, what is the definition of the hypertension during sleep? Anyone? What is the definition of hypertension? Values of hypertension to define hypertension. Systolic more than 140, diastolic more than 90 is the definition. That is our Indian definition of the hypertension. Next one. What is the international definition of hypertension? Italy, New Zealand, America, 130 by 80. So the systolic more than 130, diastolic more than 80 is an hypertensive Western population. If you apply that to our Indian population, 80% of the Indians are hypertensive. You are all hypertensive. If you check the systolic blood pressure and the diastolic blood pressure. If your blood pressure is 130 by 82, you are an hypertensive international definition. So it is a metabolic and vascular syndrome, multiple etiologies for your diabetes. Characterized by the chronic hyperglycemia, not acute hyperglycemia, unlike your COVID days. Unlike when you introduce the steroid in higher dosages, the blood sugars may go up. So that is an acute hyperglycemia. So diabetes means not acute, chronic hyperglycemia. With the disturbances of carbohydrate, fat and protein, resulting from the defects in the insulin secretion, insulin action or both. So insulin secretion defect means defect is at the pancreatic level. Beta cell defect. Insulin action means insulin resistance. So whatever the amount of the insulin producing in your body is not sufficient to push the glucose into the muscle, into the liver and into the adipose tissue. So this is called insulin resistance. So in insulin resistance fellow, you have to produce more and more insulin to push the glucose into these tissues. So there will be hyperinsulinemia in insulin resistance individuals. These two changes, these two mechanisms, that your one hand, your beta cell failure, on the other hand, your insulin resistance or hyperinsulinemia will lead to the changes in both small blood vessels and the large blood vessels. Small blood vessels, your microangiopathy, your retina, your nerves and your kidneys. So retinopathy, nephropathy, neuropathy is the microvascular complications, and your cerebrovascular disease or ischemic heart disease and peripheral vascular disease is a large vessel disease, that is macroangiopathy or large vessel disease. So some milestones. So this is the paper 1552 BC, Egyptian, oldest preserved medical document, and finally the Aratus in the 2nd century AD, the first to use the term diabetes. So what the diabetes we are using nowadays is not from this centuries, from the 2nd century onwards, coined by the Aratus. This is a beautiful report of your proud India. The 2nd and the 5th century AD, Charaka and Susruta, so physician and the surgeon. Charaka was a physician, Susruta was a surgeon. They differentiated diabetes mellitus from the diabetes insipidus. Okay, so they tasted the urine from the polyuric patients Some of the individuals' urine is tasteless and most of the people's urine is sweety. So they identified that. So even though this fellow is passing lot of the urine, there are the two reasons. One is mellitus, the second one is insipidus. And the second one, they noticed that among these people, those who are having the sweety urine, at that time no Benedicts, no glucometer, no blood sugar estimation. Krisha means lean diabetics and Stola means obese diabetics. Again they identified. So those who are passing that sweety urine, if they see the structure of the body, some people are obese, some people are very lean. So the lean people means type 1 diabetes. Very obese or the overweight people means type 2 diabetes. So they identified that diabetes of two types, insipidus and mellitus. Again, mellitus of two types. One is lean and the second one is obese. So that is type 1 and the type 2. Again, they noted that and they take an history of this population. So those people who are obese and passing sweety urine, the diabetes runs in the families. Those people are very lean. If they take a family history of the diabetes, no family history at all. Again, another important point that diabetes type 2 runs in families. Okay, they identified that type 2 diabetes runs in families. And also described polyuria and the glycosuria, honey-like urine. Described basics of the treatment for the diabetes. So then they identified that these two people, because there was no sulfonylureas, no gliptins, no insulin, no treatment at all. But still, they made people to live for longer period and they have given the parents, they used to tell to their parents that this lean diabetics, no one can save him. Only God will save him. He is going to die. Whereas that Stola, that is type 2 diabetics, we have some treatment. That is, restrict your carbohydrate, your dietary approach and reduce their body weight. That is a physical activity. These people may live for some time. But the type 1 diabetes is going to die because he is going to get diabetic ketoacidosis, pneumonias, etc. and etc. So that they describe the basics of the treatment for the type 2 diabetes, that the physical activity and the diet. They noted that lean diabetes is very difficult to manage and going to die very fast. See the beautiful observations they made. So same observations also you should make from your own patients. See, whenever you see some cases, you should have an idea about those cases. So in that way, you should see so that is the reason these Charaka and Susruta were very, very famous, not only in Indian, but all over the globe for their observations. So the latter, the pancreas takes the center stage. Earlier times, diabetes means they thought that it is a disease of the kidneys because he is passing a lot of the urine. So the defect lies at the kidney level. And the latter, some people they thought that no, this is the disease of the gastrointestinal system. Because he is taking the binge eating, polyphagia. Okay. So no, it is not the defect of the kidneys, it is the defect of the gastrointestinal system. And after some time, they thought that no, it is not the disease of the gastrointestinal system or the kidneys, it is the disease of the brain. And finally, everyone agreed that it is a disease from the pancreas. So here the Paul Langerhans, he is a medical student. He is a medical student at that time. And he did lot of the studies on the pancreas, and then he said that pancreas is having the two functions. One function is your digestive function, and the second function I don't know, but definitely the pancreas is having the two functions. So that was the first remark given by Paul Langerhans. He said that pancreas is having the two functions, and one function is your digestive function, your amylase, your digestion of the carbohydrates, etc. And the second function at this juncture, I am not able to tell, but definitely this is also identified pancreas, two functions, that is the one. And the latter, he confirmed. He said that after the death of the Langerhans and other scientists, they did a lot of the studies on the second function of the pancreas. Then they identified that yes, The first one is the digestive, as told by the Paul Langerhans, and the second one is endocrine function. The second function is endocrine function, your alpha cells, your beta cells, your delta cells, etc. And then they named the second half of the cells on the name of the Paul Langerhans. So that is the beauty of their culture. Then they named these endocrine cells of the pancreas on the name of the Paul Langerhans. So Langerhans cells is nothing but endocrine cells of the pancreas. Now the Banting. So again an orthopedic surgeon. So he posted in the department of the physiology as a tutor. And the Banting used to have a very good friend in his school days. Unfortunately, his close friend died of type 1 diabetes. He developed diabetic ketoacidosis, maybe the 6th standard or 4th standard or 5th standard. Almost neighbors, same class, very good friend of Banting, and he expired at the age of say 11 years or 12 years or 13 years with type 1 diabetes. And later Banting studied and he got the medical seat, he finished his MBBS and later he did his orthopedics, and then he has become an orthopedic surgeon, and for some reasons he was posted in the physiology department as a tutor. Now he had a lot of time. So then every day he is remembering his friend. So then he approached the HOD, that second one, that one MacLeod. MacLeod is the professor of the physiology. So he approached the MacLeod. Sir, basically I am an orthopedic surgeon, but I am posted in your department. So I knew nothing about your physiology, but you please allow me to do some research on pancreas. Okay, so for that I may give you some insights on the pancreas because my close friend died of the type 1 diabetes. Then MacLeod said, no Banting, I have only one lab. So that lab is for your undergraduates and postgraduates, etc., etc. So I can't give you a lab for your research. But you are basically an orthopedic surgeon, so forget about those things. Okay, so you are going to stay here for a few months, and again you can shift it back to your home department. So in that way, he didn't agree to spare a lab for the Bantings. And then Banting went to the principal and he approached the principal. So principal made a phone call to the MacLeod. Again he didn't listen to the principal words. Then the Banting went to the dean. Again dean asked the principal. Then principal asked the HOD, MacLeod, and finally MacLeod agreed to give me a lab, but not that regular lab. He had another lab which is unused lab. Okay, so then he asked the Banting, okay, I got the phone call from the dean and the principal to give you some lab because right now I am having only one using lab. So that is for postgraduates and undergraduates, but I have another lab. So situated on the northeast corner, I am not being using for the last 10 years. You can use that lab. Then Banting went to that lab and he made all these arrangements, etc., etc. And finally again he asked one assistant to him to do the research on the pancreas. So he gathered the dogs. So he gathered a few dogs. In some dogs, he resected all the pancreas and made those dogs go into a stage of diabetes. Because no pancreas in the dog, so obviously the pancreas develops no insulin at all. So already the dog made a diabetic dog. And then other set of the dogs, he made the pancreas duct ligated so that the exocrine function has lost and total the endocrine function is there in that pancreas, and he made all those secretions of that pancreas, ligated pancreas duct pancreas, second set of the dogs, and then he got that juice and then he injected those juice into these diabetic dogs, and their blood sugar has come down and they're living, they are eating, they are walking, etc. So he felt very happy. For all these tests, no, he needs some help. So no medical student is interested to work with the Banting because the MacLeods, the HOD is not having good relations with the Banting. So if anyone is assisting to the Banting, he is going to fail in the exams. In those days, system was like that. So finally MacLeod asked. So his name is Best. Then Best is asked to assist the Banting. That was the one of the wonderful molecules they invented in the world. Drug. The drug name is insulin. Medical ICU, cardiac ICU, neuro ICU, post-operative ICU, surgical ICU, everywhere one drug is very common in any ICU. That drug is your insulin. Your insulin. So that is the invention, a beauty of the molecule they invented. Okay, so that is a short story. Very big story, made it as a small. So this is the discovery of the insulin. Finally, see the dog. Dog name is Marjoro. Okay. But what happened? It kept alive with the pancreatic extract injections for 70 days. But after injection, after giving the extractions of these Banting and the Best insulin preparations, this dog lived for 70 days. So then what happens? This guy, Thompson, teenager with the diabetes, named Thompson, was the first documented person to receive the insulin injection. Before this photo, he is almost like a skeleton. Then insulin came to the India, all over the world. See the final one, Nobel Prize. They invented in 21, they injected in 22, they got the Nobel Prize in 23. So fast. No molecule in the world has got the Nobel Prize within 1 year of its inception. Okay? Not only that record, this is the only protein which got 8 Nobel Prizes so far. Insulin, for its discovery, for its A chain and the B chain, A chain with 21 amino acids, B chain with 30 amino acids, and naming those amino acids and changing those amino acids positions to make your analog insulins, and then your biomechanical or biotechnological invention of getting the human insulins from the E. coli. So earlier, pigs and the beef, porcine insulin and bovine insulin. Okay, pigs and the beef, they used to get the insulin from those pancreases. But later, lot of the diabetics in the world, and we have to give them a good amount of the insulin. It is not possible for the pigs and the bovine. And then they asked the engineers, biotechnology engineers, and then they made the insulin from the E. coli. So same as your human insulin. Okay. So the porcine insulin is from the pigs, bovine insulin is from the beef, human insulin not from the human beings, but from the E. coli. Okay, so the same amino acid chains, etc., etc. So that insulin we are using right now. So these are different landmarks, different drugs. So after that, the first drug for the diabetes entered into the market is the insulin, 21, 22, 23, and next 30 years, no drug. Whether it's type 1 diabetes or type 2 diabetes, only drug available is insulin. In the 50s, so slowly the OHS entered into the market. The first one is the metformin. Within 1 year, sulfonylureas. After few years, pioglitazone. After few years, gliptins and alpha glucosidase inhibitors, and then the SGLT2 inhibitors, and etc., etc. So all these for the last 70 or 75 years. So present humankind are so fortunate that for any diabetic complications of diabetes, we have a lot of the drugs in our hand. You have sulfonylureas, you have metformin, you have pioglitazone, you have voglibose, you have the different gliptins, and you have the SGLT inhibitors, and you have the regular insulins, you have the rapid acting insulins, you have the long acting insulins, you have the basal insulins, you have the co-formulations, 30 by 70, 50 by 50, 25 by 75, and also co-formulations. That means analog insulins combinations. Okay, Rizotec, your Aspart and the Deglutec. So such type of designer insulins. So now the management of the diabetes is a child's play. Okay, you have a lot of the knowledge. The only thing is you have to apply your mind to understand the pathophysiology of the diabetes. You understand the initiation of the insulin. You understand the insulin therapy. You have to understand the physiology of the pancreas and etc. So that's how. So we are so fortunate that right now we have very good molecules for the proper control of the diabetes and also inhibition of the complications or the prevention of the complications. So the magnitude is very high, a leading cause of the ESRD. Okay. So ESRD means End stage renal disease. So your GFR is less than 15. So the stage 5. 15 to 30, stage 4. 30 to 45, stage 3B. 45 to 60, stage 3A. 60 to 90, stage 2. More than 90, stage 1. So when the GFR is less than 15, you consider them the ESRD. Here only two options. One is dialysis, the second one is transplantation. Again, the dialysis of two types, hemodialysis and peritoneal dialysis. So don't allow our CKD population to go to a stage of ESRD, end stage kidney diseases. Again, the leading cause of the non-traumatic lower limb amputation, diabetes. So whenever you see an amputated fellow on the road, two reasons in India. One is a traumatic amputation, the second one is diabetic foot amputation. So this is also very common. One of the leading causes of preventable blindness. Again, the two preventable causes of the blindness in India. One is your cataract, the second one is diabetic retinopathy. Again, a cause for the diabetes. And then the major risk factor for coronary artery disease and cerebrovascular diseases. As I told you, the commonest cause of the death in diabetes is the myocardial infarction. So the major vascular disease. So all the cardiac ICUs and the neuro ICUs are filled with diabetics. If you have the 10-bedded cardiac ICU, I think at least 4 to 6 cases are the diabetics. Background is diabetes. So diabetes is a leading cause to have the myocardial infarction and cerebrovascular disease worldwide. So you need not remember these figures, but these figures are changing every minute, every second. These are the complications in India, the numbers. So these are all the complications you see day in and day out. Cardiac complications, yes. Every third or the fourth diabetic patient I see is having some cardiac complications. Injury will make the entry of the organisms into the body, and then all these organisms will cause a lot of the infections. So for this diabetic foot, three causes. One is your neuropathy, second one is your vasculopathy, and third one is the infections. So neuropathy, vasculopathy, infections, these three will cause the diabetic foot ulcers. And then of course, retina examination is very, very important. At least once in a year, all the diabetics should be screened for the retina to know whether it is a non-proliferative or proliferative diabetic retinopathy. Okay, again the kidneys, yes, at the time of the diagnosis itself, one should screen for the microalbuminuria and also urea and creatinine levels. So epidemiology, type 2 diabetes comprises 85 to 95% of all cases of the diabetes. I think in India, nearly 90 to 95%. Very high number of the type 2 diabetes are there in our Indian population. See the increase, it is an explosive increase. Tsunamic proposition. Beyond your imagination, the increase in the number of the diabetics in India, in the developing countries like India, and steady increase in the developed countries. Whereas in India, it is a tsunamic proposition. Whereas in the developed countries, it is a steady increase. Type 1 diabetes is also increasing in the society. Right now, we are seeing a lot of the type 1 diabetics also. Here, disease of the middle and old age in the developed countries, type 2 diabetes. So they get the diabetes at the time of their retirement. As well as the overweight and obesity there. Worrying trend is increasing the type 2 diabetes in the children also. What about in India? Occurs a decade earlier than in the West. Not a decade, maybe 2 decades, 3 decades. Okay, last week I have seen one child, 12-year-old girl, studying the 7th class, 7th standard, presented with the diabetes. So they approached the pediatrician because the age is 12 years now. So the pediatrician started her on insulin therapy. So she is getting a lot of hypoglycemias. The blood sugars are not under good control. So then they approached me. When I examined the child is obese, acanthosis nigricans is there. Immediately I thought that it is a type 2 diabetes. It is not the type 1 diabetes. So type 2 diabetes occurring much early onset of the type 2 diabetes. Then I stopped insulin, started her on metformin and with dietary approach, and she responded very well. So in type 2 diabetes, no insulin. Only when they have complications. See For the child, if you diagnose that it's a type 1 diabetes, how many years you have to give the insulin? Now it's 12 years till the date of the death. Maybe 70 years, 75 years, or 80 years, or 60 years. Suppose you diagnose type 2 diabetes. So what is the entry of insulin? No, only when they have the complications. Maybe sepsis, maybe myocardial infarction, maybe diabetic foot ulcer, maybe pregnancy, etc. Only use. See the change. So they felt very happy. Both the parents felt very happy. I also felt very happy in diagnosing a proper diagnosis of the diabetes. That is type 2 diabetes, early onset. So these are very, very important. So you have to understand the pathology, pathophysiology, and also the examine the patient, not the reports only. Don't treat the reports, treat the patient, treat the individual. See the individual as such first, and then only you see the reports. See, occurs even in the non-obese individual. That is also very common in Indian population. So all these type 2 diabetes means obese, overweight. No, 50% of our type 2 diabetics, they are the ideal body weight. Some people may have the lean also. Lean type 2 diabetes is also one variety in Indian population. Occasionally seen in the children, but nowadays we are very frequently seeing because of the childhood obesity. See, the more prone to develop the cardiovascular disease, Indian population, so our cause of death. Some studies suggest the lower risk of the microvascular disease. So these are the top 5 countries with the diabetes burden: China, India, Pakistan. Any wrong in this slide? Yeah. Good. India is the number 1 right now, with the highest number of the diabetics. So the prevalence of the diabetes, now the Pakistan, 30.5%. This is the prevalence of the diabetes in India. See, almost all states it is more common. Of course, South India is very common. Of course, the Godavari districts are very common. So because of high rice content, more sweet shops. Most of these studies have been done on geographically discrete populations using varying methodology and may not be representative of India as a whole. ICM study, very big sample. We are all familiar. North, east, south, west, etc. Diabetes is very, very, very high. So these are the different studies. See, as I told you earlier, 50% of the people with diabetes in India are undiagnosed. So you have the national program, not only for your diabetes, for also your cancers. Now the cancers are also very increasing in the society. So when as an undergraduate, we used to refer the cancer patients to the Tata Memorial Cancer Center, Mumbai, Adyar Cancer Center, Chennai, CMC, Vellore, or Hyderabad. Maybe 1 or 2 centers. MNJ Cancer Center, Hyderabad, and after that Indo-American Cancer Center, Hyderabad. Now, Kakinada, we are having the 2 exclusive cancer hospitals with your medical oncology, surgical oncology, radiation oncology, PET scan, MRI, CT, pathology, blood bank. Okay, whatever is there in our oncology care, we have in Kakinada. Not 1 hospital, 2 hospitals. In Chennai, in Vizag, maybe 7 to 8 hospitals. So imagine why more and more hospitals? Because more and more patients. Why more and more oncology cases? One should understand what is the reason for this increase in number of the oncology cases in Indian population especially. So I think that mostly the pesticides they are using in the agriculture. So what are all we are eating is adulterated food. Your rice, your vegetables, etc. and etc. Okay. So that is a very, very important. So now the central government is also made the impact of your diabetes and oncology. So this is a national program for the non-communicable diseases. Cancer, diabetes, cardiovascular disease, and also the stroke. So this is a national program. Role of the primary care physicians. You are all very, very good. It is important that every general practitioner be familiar with the basics of the diabetes management. We do not have the sufficient trained specialists. So how many endocrinologists we have in the society? How many physicians we are having it? So very difficult to treat the diabetes by these 2 specialties. So you people, whatever the specialist you are, whether you are a general practitioner, an ophthalmologist or a gynecologist, so you should be trained with this. Now the epidemic is spreading, not for the Mumbai to Vizag, Vizag to Anakapalli, USA, United States of Anakapalli. from there to UK, Uppadu Kottapalli. So they are taking a lot of the fast foods. So this is urbanization of the rural India. So this is very, very common. Even though they don't have any washrooms, but they have the 2 or 3 cell phones and 2 or 3 two-wheelers. Okay, so no physical activity, restricted physical activity, and more junk foods, fast foods, biryanis, bakery items, cool drinks. So these are all the reasons for your increased epidemic of this. So in all these places, you people has a major role in identifying and managing the diabetes and making prompt referral if any person with the diabetes has any complications. 20% of the adult patients in a general medical OPD will have the diabetes. So it depends. So in my OP, I think 70% of my patients are the diabetics. For you, maybe 20%. For other person, maybe 10%. But definitely, lot of the people are having. See, the people sitting there, or most of the people are the diabetes without knowing that they are having the diabetes. Okay. So from tomorrow onwards, you check the blood sugar in all the people. Whatever the investigations you are writing on the paper, HB, etc., please add blood sugar also. See, whatever the diabetes awareness in India, only 43% individuals have ever heard of the diabetes. 50% they do not know that diabetes can lead to organ complications. More than 80% they don't know the risk factors for the diabetes. What are all the risk factors I told you so far? 50% do not know that diabetes can be prevented. Reversal of the diabetes is possible. Prevention of the diabetes is possible. Prevention of the complications is also possible. So these are all the things you should know. So you people has a major role in educating his patients and their relatives about the diabetes so that they seek the detection and the care early. So medical education is very important. You should behave as a teacher as well as a doctor. Okay. So you have to teach about the prevalence of the diabetes and etc. to your own people. So I stop here.
Thank you.